Okay, hi everybody, welcome to my presentation for Dysuria of the case study. Here we have the chapters 1 through 7, the different things that we'll need to address. And the first is the differential diagnosis of dysuria. First we have this combined as a differential only for dysuria for males and females, just based on the one symptom. This isn't the differential specific to this particular case study. I'll link that one in the comprehensive vindicates with the treatments and the signs and symptoms in a PDF down below. Okay, so we have about the patient. Okay, for HPI, an 80-year-old female was brought to the emergency department by her son due to foul-smelling urine and mild confusion. She is noted to be lethargic, tachycardic, and febrile. The son went to check on his mother this morning and noticed she was a little difficult to awaken. When he helped her up to the bathroom, she noted that her urine was pretty bad smelling. She was in her usual health until this morning. Okay, so for past medical history, for constitutional, she has a fever, but no chills or recent weight loss. She's currently lethargic. HENT, she denies changes in hearing or visions and does not have a sore throat. Cardiac, she's denied palpitations or chest pain. Respiratory, no cough or shortness of breath. Although it was also mentioned that she is a little bit, tachypenic for what I think, just because of her other symptoms. I mean, it's within range. Abdomen, denies nausea, vomiting, diarrhea. No hememesis. GI, she has foul-smelling urine and darker colored urine. And so those making differentials based off of this could definitely be something like cystitis. Musculoskeletal, negative for falls or myalgias. Neuro, she's not dizzy, doesn't have syncope, and nothing is numb. Hematologic, no bruising or bleeding. Psychosocial, she denies any depression or anxiety. Past medical history, so she has diagnoses of hypertension and osteoarthritis. Surgical history, she has a right knee replacement. Family history is unavailable. Social history, she does not smoke, she does not drink or use illicit drugs. She lives with her son and is widowed. The current medications she's on is amlodipine and Zaloxolib. And so I've just made note of those and the different adverse effects that those could have. And then she's 80 and doesn't have any known drug allergies and female. For her physical exam, it's important to make note that she's ill appearing and mildly lethargic. Her vitals 38.1, pulse 110, respirations 20, BP 105/67, SpO2 93 on room air. She's 5'3", 135. And so her vitals, her temperature is elevated. She's hypotensive. Her respirations are within range. However, everything else is kind of suggestive that maybe a little that may be trending up. Pulse, tachycardic, and she's 93 on room air. HENT, normocephalic, atraumatic dry mucous membranes, and so maybe she's a little bit hypovolemic at this point. Clear, non-esoteric, and everything's clear. Neck, no JVD, bruise, or thyromegaly. Cardiovascular, tachycardic. But everything else is fine. Respiratory, clear. Abdomen, soft, mild suprapubic tenderness, and so along with other things, maybe again pyelonephritis, cystitis, bell sounds to all four quadrants, no masses, no splenomegaly or hepatomegaly, MSK, full range of motion, all extremities, no, neurologic, she's lethargic and oriented to person and place only. Intake inventory, she's warm, moist, but doesn't have any bruising or rashes noted. Okay, and some of the things that I found concerning right away, just because of her age and how quickly older people can decompensate, were her vitals, her acute change in mutation, the fact that she's lethargic, tachycardic, and febrile. She seems like she could be becoming hypoxic, and then the fact that she's incontinent as of this morning, and that her urine was malodorous. Um, Maybe hypovolemic or dehydrated just because of the dry mucous membranes. She's ill appearing, which is concerning, and she's diaphoretic. And then she has a significant past medical history of hypertension and osteoarthritis. And so, well, there's at this point, it doesn't there's we haven't got to the labs yet. Um, but she is starting to meet the SIRS criteria, and so although her white blood count isn't past 12,000 as of this point, which we'll look at here in a second, I would be concerned about how quickly she's deteriorating, especially if she was fine the previous day up until only this morning. I would start to be concerned about SIRS and initiating protocol for sepsis. And so drawing labs right away, the 2 blood cultures, and giving her IV fluids. Okay, so for her urinalysis, there was blood, nitrates, and leukocytes, and then the crystals, and then the culture was definitely positive. So there's granular casts, which is important to note because the granular casts, also described as muddy brown casts, are going to be the dead tubules that are excreted through the urine from her kidneys, just because that kind of suggests some sort of acute renal failure. And then there's red blood cells and then the white blood cells, which support the differentials of cystitis, pyelonephritis, and then possibly sepsis secondary to that. Okay, for the CMP, her glucose is 123, and her past medical history doesn't describe her as being diabetic. And so this could be because she's becoming septic, and so her sugar will be high, but then eventually become lower as that escalates. UN34, creatinine 1.5, again suggestive of AKI. Calcium 7.6. She has osteoarthritis, and she could be becoming septic. Okay, total protein 5.9, albumin 3.2, and then the GFR is 33. And so we have to keep that in mind, especially when we're calculating medications. Her CBC with diff, the hemoglobin, and her hematocrit were the only 2 things of note, but I did also notice that some of these are trending in one direction versus the other, and her white blood cell count is not over 12,000, it's not even over 11. However, you still can become septic even with a regular white blood count. And then in terms of the AKI and the azotemia, so first my suspicion would be of cystitis. This video isn't particularly showing cystitis. This is actually showing crystals or stones, but it's just kind of the underlying pathology that I have it displayed here for. Pyelonephritis, and so she's going to be displaying the features of uncomplicated cystitis, and then also her renal insufficiency, and we would want to rule out any obstructions that we have. And AKI, and so this is going to be what's maybe causing those granular casts, disruptions in the blood supply, in addition to comorbidities, as we've mentioned and discussed, may have caused renal failure due to the acute tubular necrosis. This is seen more often in the elderly due to the decreased ability to concentrate urine, predisposing to fluid loss. Some of the drugs that she's currently on, like NSAIDs, antagonize the afferent vasodilation, while the ACE inhibitors affect the efferent arterial constriction. And then here we have some of the most concerning things for differentials and diagnosis: urosepsis, renal injury, acute pyelonephritis, as evidenced by the granular casts there in the middle. Renal azotemia, pre-renal azotemia is important to note, and then acute tubular necrosis. Again, that's going to be evidenced by the granular casts. Okay, so for pharmacological treatment, we're going to definitely do the dual antibiotics, pantoprazole, acetaminophen, ondansetron, fluids, and norepi to keep her mean arterial pressure above 65. Boluses for the fluids, and then she is hypocalcemic, but I mean that could be helped by the boluses in the saline. Um, the other thing, some of the labs that we would definitely want to order is to order that 12 lead and to keep her on telemetry. And finally, the orders. Okay, so for the admission orders, obviously inpatient. Some of the important things that I want to talk about are some of the diagnostics additionally. So, like I said, because of her electrolyte imbalances, the EKG 12 lead to maintain and take a look at her heart rate rhythm, PHS x ray, renal ultrasound. Of course, we're going to be looking for any physical obstructions, and bladder ultrasound to see if she has any retention in there, or even an obstruction there. The renal ultrasound will also help us take a look at to see if the kidneys are smaller than normal, if they're if they're not getting the blood supply that we need. And then lab orders, lactate's important. Also, definitely troponin. By two sets of blood cultures prior to the antibiotics, and then the chemistries, especially for like things like vitamin D, just because she has the osteoarthritis, and the calcium and how the calcium affects kidneys. Let's see. And then the one of the other things is the urine, and so we would want to do maybe an add-on for urine, sodium, urea, and creatinine. And with that, you could do the functional excretion of sodium, and that's going to be tell us if it's a pre-renal azotemia or an intrinsic renal azotemia. Um, we would need simultaneous measurement of the serum sodium, urine sodium, serum creatinine, and then urine creatinine. And as long as she's not on any diuretics, you could do this calculation and determine whether or not it's above or below 35, giving you evidence if towards making a conclusion if it's pre-renal or intrinsic. And then lastly, hemoglobin A1C to see if she has high sugars continually or not. And then a PTT for coags. And that's it. Thank you for watching. Have a good day.